Okay, good afternoon everybody, and we're now formally back in a live stream session again, and welcome back after the break. This is a time where you get to hear less from me in the chair, and I'm going to pass across to Derval MacDonald, who's a very familiar broadcaster, to yourselves to introduce this session and introduce our panel discussion that we're going to have now. Thank you. Over to you, Derval.
Thank you very, very much, Paul. And as you just heard, my name is Derval MacDonald. It's really a privilege to be here with you this afternoon. This year marks the 20th year that I've been in journalism. Most of that time was spent as a legal affairs writer, covering civil and criminal justice policy, and also working on the front line in our court system. Our court system, both civil and criminal, is a very small, only a small lens through which to view the issue of drugs, but it was a significant one for me nonetheless, seeing the impact of drug use in our district courts, where we prosecute a lot of minor offences, including possession, public order. I saw that right up to our more serious divisions of the courts, where the state was trying to crack down on cartels and serious users. Perhaps most heartbreakingly, where you really saw the impact of drug use was in the childcare divisions of our courts, and also in our family law divisions, where you really get to see the impacts of it. What I've drawn from my own experience, just that very, very small lens, is that many of us come to the issue of drug use with very fixed opinions and views about it, while at the same time perhaps being blind to the reality of the lived experience of those who use drugs. I'm stealing a line from one of our panellists today who tweeted earlier this week: some of us use drugs recreationally, some for medical reasons, some of a dependence, and these are all very different things. Thank you, Sharon Lambert. You might be fortunate enough not to have experienced the trauma that have led many on the path to drug use. You might be fortunate not to live in an area of high social deprivation, where the impacts of drug use and the lack of treatment services are most felt. You, or someone you may know, may have dabbled in drug use but had the resources, how those resources presented themselves, to prevent that recreational use morphing into something more serious, a dependency, a criminal conviction, or worse. You might think that drug use is a matter of public health. You may think that criminalisation still plays its part. But I think what's not in dispute is that behind every statistic of drug use of a person who uses drugs is a profoundly human story of a loved one, a colleague, a neighbour, or a friend. And no conversation can take place without them. As the chairman has said, this person-centred perspective, the lived experience, is something that is critical to your deliberations. And obviously there's going to be a dedicated forum about that in May. But to set the scene, as it were, today, I'm joined by an incredible panel who are going to speak to that lived experience. I could do a fireside chat individually with each and every one of them, but they're going to talk to us about the causes, the consequences, and what they think should change. I'm joined by Pauline McKeown, who is the CEO of the Coolmine Therapeutic Community, the first specialist drug treatment centre of its kind in Ireland, which I think celebrates its 50th anniversary. 50 years this year. Andy O'Hara to my left, who is the coordinator of Ishka, an amazing organisation that provides advocacy for people who use drugs, and critically is led by people who have direct experience of drug use in all its guises, and you'll hear from Andy. Dr. Sharon Lambert from the Applied School of Psychology at UCC is not just one of this island's foremost academics on trauma. She also has first-hand experience having directed services for homeless and people who use drugs. Last but not least, joining us from a van somewhere in Fermanagh, I think, is Philly McMahon, the former Dublin GAA player, who, if you'd been listening to the news over lunchtime on the Saturday with Colm Ongoing programme, spoke so powerfully to this issue. For those who don't know, Philly's brother, John, was a heroin addict who died in 2012, but Philly has been remarkable. He has used their family's life experience, John's stories, to become an incredible advocate for people who use drugs and for their families. You'll have an opportunity to ask questions of our panel. I don't need to ask you to take part, because having listened to the last session, I know you will. Okay, Sharon Lambert, I'm going to start with you, because let's start with a really obvious and uncontentious issue, which is the fact that human beings have been using psychoactive substances since the beginning of time. But if we'd heard, even with the caveats around collecting data, we do have some of the highest drug deaths. We do, in certain areas, some of the highest drug use. Paint us the picture, as you see it, of the reality of drug use in Ireland.
Well, I suppose there's been loads of speakers this morning that have presented the statistics, and some of the things that have stood out is that you know, 90% of people who use drugs do so for exactly the reasons you said. I think they discovered some cave recently where they said 3,000 years ago there was evidence of somebody using a psychoactive substance. So people have always done that, but then you have a group of people who experience very significant harm. And I think it was Professor Ivers, you know, spoke about some of the reasons that drive that. So then the question is it the drugs that are the problem? Or is it the other issues which you have touched on, like poverty and stress and trauma? So some people who take drugs, lots of people take drugs and they do so for different reasons. But some people who take drugs, what it does for them manages emotional pain, and that causes them a huge amount of social difficulties. And actually we need to tackle those things that cause emotional pain, like poverty and marginalisation and exclusion, and the other things that can happen as a result of that.
And Pauline McKeown, using drugs that we've heard is a rite of passage for many, but not everybody's outcomes, as you've heard from Sharon, are the same. Some walk away, others suffer profoundly. For you, what is it that distinguishes the divergence of those paths?
I think what distinguishes the diversion is basically the social community capital that someone would have around them. So, for example, in coal mine, the clients that we would work with would be people who are homeless, people who have maybe came directly from the prison, homeless pregnant women, women with young children, traveller community members. So it's members of our society that are coming from deprivation and multiple adversities. A piece of research last week from Dr. Sarah Morton looked at, well, it was titled "You Can't Fix This in 6 Months." And I think it's a very apt title because what it was talking about is the complexities and the multiple complexities that women face as a result of the homelessness, poverty, transactional sex at times too, abuse, domestic violence. So all of those multiple adversities are there, and therefore access and treatment isn't always easy.
I want to go to Philly, if you can hear us okay. I know I should perhaps explain that you're doing live punditry this afternoon, and that is why you're sitting huddled in the back of a van. But so much of the trauma that leads to drug use, and particularly when it morphs into dependence, it's undiagnosed, it's unresolved, as was the case with your brother John. Can you tell us a little bit about him, Philly?
Yes, first of all, apologies that I'm not there physically. I was there this morning. I look like I'm in one of Joe Biden's Secret Services vans here, but apologies I'm not there physically. And yeah, well, I suppose for us, it wasn't until later in John's pathway in terms of addiction, his mid-20s, late 20s, that we discovered that John had schizophrenia. So for a long time, based off our education as a family, what possibly the wider social education was based off it being incriminating to take drugs. We kind of are educated to, I suppose, be ashamed, to be embarrassed, and that stigmatization was crucial in all of that education. So if we had known, what we knew at the age of John's age of 25, 26, 27, we definitely would have treated it as a mental health issue rather than, looking at John's addiction. We would have looked at the underlying issue, and we would have definitely, I think, we would have dealt with it a little bit differently, yeah. And
Philly, just on that, until that type of drug use, that dependence is in your home, you might not really know what you're dealing with, and families are often at a loss themselves on how to deal with it. What do they need when they're supporting a loved one whose drug use has led to a dependence that is a serious threat to them and perhaps to others?
Well, I think it's important for the Assembly to understand, first of all, what it's like to have somebody that's struggling with addiction in your family. your day to day is completely muddled. You know, you're constantly thinking of your loved one. For me, you know, it was where I was walking to school, coming back from school. Where was my brother? You know, if he was on the blocks we grew up in Ballymun, the flats. So if we were on the blocks, I would try divert, go to a different, you know, different area where we lived, because that's what my education was. That's what the family was educated on, and it's, you know, it's just we take for granted when you don't have somebody that's struggling. You know, we take for granted the day-to-day stuff that we do, like work, school, sport, possibly. But for me, the only thing that took my mind off my brother was playing sport. And even when I was playing sport, he was probably on my mind because I was venting the energy that I had on the pitch. So it's extremely difficult. That hasn't changed. That hasn't changed from the existence of our policy, from the existence of people taking drugs. I'm sure we've had those struggles as family members, and as it's always been said, when you have a loved one that's struggling with addiction, your family goes through the addiction side of it, you know, goes through the recovery side of it. And probably the most difficult part is the bereavement part of it, you know. It's, you've got a lot of questions that you know, you want answered. And particularly when my brother John passed away, when I became a bit more of an activist in the area of addiction, I understood that there's a lot more that can be done.
Absolutely. I want to just go to you, Andy, because your organisation, it's sort of unique because it involves people in that peer group and work that you do. It's people who have direct experience of it. What has been your own experience, and what, you know, and the experience of your colleagues who are out there in the community working with and trying to empower people who use drugs?
Yeah, it's a big question, and I suppose, like, what's my experience? And, you know, someone said to me not that long ago, you know, you should write a book. And as much as my ego would like to believe it'd be a good book, it really wouldn't. Because the reality is it's not a unique story. It's been told 1,000 times. And sometimes I think that's a mistake we make, because we focus on people that probably got to a better place. And we see, like, if they got out, maybe other people could have. And the reality is the story isn't about people who have managed to get well or are in a better place. The story is of the people who haven't made it, like Philly's brother, my own brother. I mean, I was at a funeral of a young man not that long ago who died of a drug overdose, and it was right out in the area. We travelled, we went around the graveyard, me and a couple of friends, to look at all the people that we knew, which was loads. And the remarkable thing wasn't the amount of people that we knew, that we remembered that was right. It was the amount of people that we walked past that we had forgotten about. And when we talk to people in the organisation, like I said, the organisation is made up of people who both are working there and are volunteers, and it's a lived and living experience. And it's important to say that, because it's, I think sometimes there's a hierarchy of, like, well, if you used to use drugs, you can have a voice, and if you're still using drugs, you can't, we'll still stigmatise you. And what do people tell us? They tell us they want to live. They tell us they want to realise their full potential. They tell us they want to have a stake in society. They tell us they want to be involved. Like you mentioned earlier on, I think one of the big things we find, we're really lucky because of the work we do. We just get to meet people where they're at, and we just get to see the magic, because people are brilliant and people have so much to offer, and they're dehumanised, they're stigmatised, they're criminalised, and they're written off. And when we're talking about people who use drugs, what do we mean? In our case, you know, it's really the people who've been most impacted, but who have the most knowledge. But they're the people who are excluded the most, and they've been excluded for most of their lives. So their experience of engagement is poor. But when we do outreach, we do groups, all peer-led, all have peers involved, we do research, we do different things. And what they have is a really strong analysis, right? Because you mentioned it there. What's this about? It's about looking at drugs and drug policy and looking at the causes and the consequences and the responses. And what we get when we do workshops, we just set them up and people explore the issue through their own living experience, and they have a really strong analysis of what's going on.
And these are the people that you work with in particular, are those who have experienced, I suppose, the worst impacts of it, because it is, you know, chronic dependence, it is death, it's that real devastation that we see in communities.
Yeah, and it's like, but I think the key bit is that, like, there are people that, like look, I mean, are they well represented in decision-making place? Because we go back to, look, poverty is being mentioned, trauma is being mentioned, environments, and we have to accept, like, drugs are across all demographics. When we look at the communities are the people worst affected. Pauline mentioned travellers and stuff, and certain groups and different. And you know, if you look at the numbers of the statistics of people who end up in care because of neglect, it's linked to poverty. If you look at the people who end up in prison connected to drugs, so it's particular groups of people and particular groups of drug users, people who use drugs, that get stigmatised and criminalised the most. And therefore, we see them as just a problem that we may or may not choose to fix. And therefore it's okay if they're discarded because we see them as greedy and selfish. But if we flip the paradigm and look at some of the work we do in other organisations, you'll find out that they're actually part of the solution. They need to be able to be part of the process of driving the change. And that's the success you'll have.
To have their voices heard. Pauline, I want to talk to you about something that is really kind of prevalent when we talk about drug use. There are many layers to it, but shame and stigma, class, the language even that we use. And, you know, they're so pervasive, we know that they can inhibit access to treatment, to recovery. To what extent, I wonder, does this stigma actually increase the risk of drug use, particularly intergenerational drug use? Yeah. And I suppose a question that I often ask is, what is it that middle-class drug users have that those on lower incomes do not?
Yeah, well, I think that the stigma and shame just has a significant role because it's discrimination, as Andy has said. So based on where you're from, based on your experiences, you may not get offered the same service, or you may not be able to access the same service. And I think when we layer that into society today, you know, we're seeing increasing levels of homelessness, etc. as well. And, you know, that's the children who are going to grow up and have a rite of passage to experiment potentially with drug use. And if there isn't a resilience around those children, and as they grow up and there isn't responses in place, then we will lead to more problems, you know. So,
and how does that fit into the intergenerational, you know, where you're literally perhaps in 2 or 3 generations of families who are caught in that spiral?
Yeah. So in a study we done in 2015, we implemented a program called the Parents Under Pressure program. And what we did was we sampled the participants that were accessing our services. 4 out of 5 grew up in households where one, if not both parents, were in addiction. They had deep, deep distrust of social services. You know, through their own experience as well. And some of the women we would work with, they would, you know, quote that, you know, having gone through labour, they would cry with the fear that their baby was going to be taken off them. So, you know, our response, our societal response by state agencies in service delivery can improve. It must improve and needs to improve.
And you mentioned something just at the outset, a phrase that just struck me, was it the social and human capital? Yeah. Is that what kind of allows some to get out of a potentially dangerous path? Essentially middle class users.
Yeah, I mean, if we look at recovery capital, the term that we use around recovery capital, that is for people to have their physical health needs met. That is for people to have the community around them that can support them. That has to include, and I think today in Ireland, there's a good understanding that we need to look at a holistic view. So it's not so much the drug itself, that could be any kind of drug that could lead to the problem and the dependency, but it's actually all the components that need to be sorted. That people who come into treatment, people who are using drugs that Andy's talking about too, you know, they need access to housing, they need access to mental health care, they need access to physical health care as well. In doing that, we can start to break that generational cycle of addiction. One response that we have is mother and child residential treatment service as well in Coolmine. And that means that a pregnant woman or a woman in addiction with young children doesn't have to put her children into care or into the care of an extended family, can actually access the treatment that she needs, work on the clinical medical aspect, so if there's a detox element required, work on the therapeutic aspects, the group work, the therapeutic community or therapies, with trained and supportive staff. And then we can look at that integration piece. And that has to include access through to education. you know, an example, one of the clients who'd accessed our services recently, from the age of 11 was in institutional care. So from the age of 11, from an inner city area in institutional care. By the time that person was 18, they were straight into the prison system. At the age of 16, they left the youth system and straight into the prison system. Homelessness, a massive feature. Majority of the family in prison too. You know, this is the reality. No literacy, limited literacy, hadn't had access to education either. That person, because a pathway was created from the prison through to treatment, is now working as an apprentice in an electrical
And something
company.
that just underlies everything, access to services is so key. Yes, you can.
Yeah.
On that point, because it speaks to a couple of people we were working with is probably about a year ago. Two men. Two had very similar experiences of drug use. Two came from very different backgrounds and had very different outcomes. They both experienced a lot of, but one of them was from council estate in the north side, one was from a very wealthy background on the south side. Two of them had a very powerful experience of drug use. Both heroin intravenous drug users. Both had experienced trauma. Both had their partners die. Both had issues with their children. But the guy from the north side had got his kids taken off him. He went and committed crimes and he got criminalised and he got sent to prison. When he came out of prison, he had no house. He became homeless. That guy went in and out of drug use and is still doing that. And then when he tries to get back into treatment or go to treatment, it's about 18 months to go. The other guy, very powerful story, but along his journey, he had a system around him. So his kids never went to care because he had a family who had resources and stuff. He had access to treatment when he needed it, so he was in treatment 4 times before he became drug-free. When he came out of treatment, he had a house, he had education, and his father got him a job, which is a brilliant story. But if you look at that, that's a structured analysis of what doesn't work, what policies don't work, and what you need to get through this.
And Sharon, can I just ask you, I imagine that, well, I've seen it, but I imagine that stigma and shame must be particularly hard, and Pauline touched on it earlier, about those who have really complex intersectionality. So it's not just one thing that's inhibiting. It could be a woman, it could be a pregnant woman, it could be a member of the traveller community. It's people who are already on the margins and who don't perhaps even have any chance of accessing the type of support that they need, that others might be more enabled to do so.
Yeah, so in relation to stigma and shame and substance dependence, almost everybody who's in substance dependence experiences stigma and shame, and it actually delays accessing help. And sometimes when I think about it, I think when I was a teenager, we didn't speak about mental health, and when somebody died by suicide, it was often...
In euphemisms.
It was a farming accident. And then, you know, we totally changed the way we think about mental health in this country. And now, if I was not feeling great in the morning, I can go to a GP and I can say, I'm feeling quite down. And there's, you know, we still have some way to go, to be honest, in that. But, I mean, it is nothing compared to where we were in the 80s and 90s. Where we are now with drug use is where we were then with mental health. So if I'm at home and I'm drinking too much, or I use drugs and now it has turned into something, a more complicated relationship for me, it's very difficult to go to somebody and say, I think that I've got a problem with my drug or alcohol use, because we have shamed people and we have made people feel like it is their fault. So there's internal stigma, and then there's the external stigma from society, and the policies, the drug policies that tell you that you're a criminal if you have this issue feeds into that as well. And Austin O'Carroll, who's a GP in North Inner City Dublin, he did a PhD on internal and external shame. And one thing I know from working with people who use drugs at a level where there was a dependence, nobody feels as bad about themselves as the person themselves. And you know, and it can be so difficult for them to come forward. And if we don't create a compassionate, caring environment that says, I understand that you're struggling, and I want you to get help, and we don't think that this is your fault, and we don't think you should be treated badly. But one of the most important things that has been said on this stage is about social capital. So I'm Dr. Sharon Lambert in UCC. If I developed a dependence issue in the morning, my social capital, so I'm actually from a working class background and I've benefited from social mobility. I did not know what social capital was when I was young. I wish I had. Because when you were in an area, if you're a traveller, if you're a member of a working class community, one of the things you don't know about is social capital. So you think that you exist in this community because you're just not as good as anybody else. And you don't understand societal structures.
It's something, Philly McMahon, you have described well, I suppose sometimes the so-called war on drugs as, in fact, a war on class. We see it with young men in particular who perhaps get a conviction at an early age, the difficulties they have in accessing work and something else, or everything really. What role does stigma and that shame play in areas of high social deprivation, the kind of community that you came from?
Yeah, well, I suppose that anybody who believes that the war on drugs works are wrong. It's something that came from the States in general. You know, you had alcohol prohibition fail, and a lot of the resources were put into the DEA, which then transpired across to Europe and other countries. And unfortunately, when you look at the population in our prison right now, it's heavily populated by people from working class communities. Now, the question is, why is that? Considering that there's drugs in every profession, there's drugs in every social class, in every community. So then why does our policy facilitate for one and not the other? So essentially, that's what that means. A social class, it's a war on social class rather than war on drugs.
Thanks, Philly, for that. That sort of brings us into one of the more perhaps challenging areas, and that is the issue of how we as a society approach drug use. And it's an area, I think, that's laden with complex concepts. There's often a lot of confusion, especially around terms such as regulation, legalisation, criminalisation. Sometimes they're conflated, so bear with us, if you will, as we delve into this topic. Trigger warning, you may hear a lot about Portugal in this section. I'm going to go to you, Sharon Lambert. If trauma, and I know it's a broad generalisation, but if trauma lies at the root of drug use, the kind of that serious, the dependence, the chronic dependence, are we right to criminalise people who use drugs?
Well, I suppose the first thing to say is not everybody who is drug dependent has experienced trauma, but we've done lots.
That's why I said just more broadly.
Yeah. But like all of the studies, including the research that I've done myself, will show that it's anywhere between 80 to 90%. And actually, one of the issues we have with how we measure and define traumas is about 17 different scales out there that measure trauma. None of them cover all of the different traumas that someone could experience. So that's the thing, is that we know that a very significant amount of people who have drug dependence have experienced a psychological trauma. So if they have struggled to access the services, and we've spoken about access, if they've struggled to access the services that they needed at the time that they needed it, and then they found this substance that says, I can function, I can cope, and I think sometimes about the Two Norries podcast, because they have a lot of people with lived experience on that, and what you often hear is people say, if I hadn't found that particular drug at that time, I think I would have died by suicide, because I couldn't cope with my own emotional pain. So, like, if that's what people are telling us, then how can we turn around then and harm them further? Because, Andy's talking about the people who do, come through recovery and they go off and they do apprenticeships. If they have criminal convictions, I work in a university, I can tell you that it matters. There are people, absolutely fantastic students, who come into us, into universities all of the time, and they will apply for various different jobs or placements, and lots of those places do.
And it comes to that
guard
box which you have to tick.
Yeah, and then you have to sit there and you have to watch them retell their story over and over and over again about something that is 12 or 13 or 20 years in the past. And I think, why haven't they been allowed
to have their conviction spent, to be able to move
on?
And
because if we don't start to really look at this in a health way.
But Sharon, it's interesting because sometimes the strongest opposition to any decriminalisation or liberalisation often comes from the families of those who have lost loved ones, who perhaps they support prohibition, perhaps because they don't want to see any use extended. And what do you say to those people today?
I mean, Philly talks, really quite well about drug-related bereavement and how complex and how complicated it is. I've done a study on it myself. I have a PhD student, Daniel Callahan, who's looking at drug-related death. It is not the same for everybody, but there are lots of similarities. It is a complicated grief because it's a grief that carries shame and stigma. And if you have a child who died in a car accident, for example, this is what families tell us, that people say, God, that's really sad, but if their child has died as a result of a drug-related death, people would say, well, sure, it was kind of their fault. So then there's a different grieving process. What I'm going to say is, I'm going to actually leave it to the words of the families. And there was a really excellent article in Hot Press yesterday from Aileen Malone.
I read that, yeah.
Her daughter, Dara, is dead 6 years now. And that article is very comprehensive. And it covers all of the different complexities that go on around that. And Philly has spoken about those as well. And that's who I would leave those words to, rather than me saying how a family should feel. I think that article yesterday from Aileen Malone.
But you appreciate perhaps the complexity of the response. There is no one size fits all from everyone.
I think what we should do is we have to look at research and say what do we know, and we know that the further you push people into the margins, the more dangerous you create situations. My PhD student just finished looking at people who use drugs, who have lost somebody who is using drugs. And if you're drug dependent, if I was using heroin, I can't just stop now this minute because I will become very unwell and I mightn't be able to manage my own emotions. And if Andy and I were using heroin here together and he started to overdose and I dial 999, I have to leave.
Because you yourself could be
arrested,
potentially implicated in a crime.
And I'm going to be frightened. And then, God forbid, if somebody dies, then what's the impact? So it's really, really complicated. And the last thing I'm going to say about this is it can be a very emotive issue and it can be very polarized. I think that the most important thing is I know that I don't know everything. I know that I don't know everything. And I have to always be prepared to know that and to listen to other people. And I haven't walked in other people's shoes either. And sometimes when we've lived particular lives, particularly people who might have lived a particular privilege, it can be very difficult, really difficult to understand how hard life can be for other people.
Yeah, and I suppose, Philly, one of the things we're talking today really is about the conversation. It's about communication. And to some extent, I think it's true to say we've probably glamorised the nefarious work of a lot of the drug cartels, whether it's in our TV screens, books, podcasts. There's certainly a market out there for this material. But I just wanted to ask you, is the stigma of a criminal conviction for younger people, is it, like Sharon said, a huge barrier? Have you seen that? And also maybe to ask you, what are your views on the effect of the criminal law on supply and demand?
Well, first of all, I'd like to kind of start with the glamorization of the media in around criminalisation. This policy that we currently have works, and that might sound strange because I've been somebody that's advocated for change, but it works for certain people. It works for solicitors, it works for the media world, it works for politicians to an extent, judges, but it doesn't work for the people that actually need it to work for. So that's, when I'm working in Mountjoy Prison, and, there's two aspects to you going to prison. One is that your liberty is taken away because you've committed a crime. And the other element to it is that you have to be rehabilitated before you reintegrate into society. So as soon as, if I've worked with a prisoner for 2 to 3 years, rehabilitating his journey, and he gets out, 9 times out of 10, there will be a journalist standing outside the prison taking pictures of that individual, and the story will be in the paper the next day. And that prevents that person possibly getting a job, possibly getting a house, possibly moving on in a new direction. So there's a huge part, there's a huge, I suppose, industry around glamorizing crime, glamorizing drugs. But when people go to prison, my brother John took drugs before he went to prison. When he was in prison, he took drugs. And when he came back out, he was still on drugs. And in many ways, when you go to prison, you become a better criminal. You know, I've had individuals in my programs that had petty crimes, you could say. Like, there's 2,500 prisoners in our prison system today that are serving less than 12 months. You know, our numbers have, from 2001, when Portugal changed their model, we've had a 20% increase in prison population. And we now have today, I think it's between 30 or 40 prisoners sleeping on floors and mattresses. So it's working for somebody, but it's not working for the people that it's needed for. You know, I remember my first time in Mountjoy going into the A and B, the wing A and B, where it's kind of for protection. And I remember speaking to a guy that I knew from Ballymun, and I said to him, "What are you doing on protection?" And he says, "Look, every time I kind of have time to think, I think about the person that sexually abused me, that put, you know, every time I'm trying to go to sleep, I kind of imagine his hand over my face, and I have to then take sleeping tablets to go to sleep, and I get P19s, which is the punishment you get in prison for taking drugs or having phones or whatever it may be, or any kind of assaults." So he kept finding himself kind of getting into trouble in prison. Now, that's an individual that needs, you know, support differently than the criminal justice system. And I think the problem we have is that we have, in this whole area, we have more intervention through criminal justice than we do from a health intervention point of view.
And that's something I want to bring you in on, Pauline McComb. Is it a public health intervention? Is it a criminal justice intervention? Is there room for both when we look at the scale of drug use?
I think if we're looking at small amounts of possession, then we need to look at the public health response.
A la Portugal.
Yeah. And I think that, you know, given the clients that we'd work with in coal mine, you know, the charges that have incurred result in custodial sentences. They, as Philly has very well described there, they get into the prison system and it just perpetuates.
Revolving door.
It's a revolving door. And that, so I think that...
And often for many people, being in prison is safer for them. They feel it's safer for them.
Yeah, and many of our clients would say, well, at least have somewhere to sleep, you know, because they may not have that when they're not in the prison. So I do think that we do need to look at that public health response. But parallel with that, then we need to resource that public health response. Because by offering the public health response, we need to make sure we can't create another letdown, insofar as we need to make sure we have the treatment services available, rurally, urban. You know, this is a national issue. This is a national problem. It's not just confined to inner city areas. We are looking at our rural communities, you know, be that Kerry, you know, Mayo, you know, drug use is there. And
can we understand, or do you understand or appreciate the fears that people have around any relaxation, particularly in relation to illicit drugs and the very many different types that are constantly coming onto the market, that perhaps people will fear that if there's no break there, or how do we distinguish between personal use and then the much bigger problem of distribution and supply?
Sure. And I think that there's a couple of models that we currently have in Ireland that are being piloted in the Midwest, in Cork as well. So it's this screening and brief intervention. It's using an evidence-based approach where there's a multiple assessment process to establish exactly what's going on in the person's life. And I think that that is the mechanism by which this can roll out and potentially aid people. We will intervene earlier in the trajectory of someone's drug using career. We'll intervene earlier with a health response. And I think that that would be a positive. piece and a positive for young people growing up as well.
Andy, can I ask you, sometimes it's said that what you permit, you promote, and there's a fear amongst many that perhaps that decriminalising certain drugs, particularly those, and we've heard in such stark terms, that cause particular harm, and we're looking at harm reduction. But even in advance of the Assembly, there were, medics and others out cautioning against the use of certain drugs, saying that there needs to be huge public awareness campaigns. But do you think that the fear that any relaxation or liberalisation of the law would lead to increased drug use, is that fear validated, or is that a jump you feel we have to take anyway?
Well, I think we have to be realistic, and we have to say, because I think there's a misconception that people that are in favour of decriminalisation are talking about the promotion of drugs. What they're being is realists, as Philly said, like the war on drugs. Drugs are more available, they're cheaper, and they're more potent. And like drugs are available in every parish in this country. Like when we looked at heroin, we had the same fears in the 80s when heroin hit. Here we are 30 whatever years later, and we have more drugs, more prevalent across more demographics in more communities. So we just have to be realistic about where we are. And what we know is, as Philly said, look, for some particular classes or for some particular professions it's worked, but we know across the board the criminalisation of people hasn't worked, the stigmatisation of people hasn't worked. And I'll say this even just around, because class is very important, and I think it is a class war, but it's also commonalities between classes, because there's plenty of people, like, let's say for instance we went out this weekend and we went into pubs and houses and we arrested everybody that was taking drug recreationally that never presented to any service, and we brought them through the court system tomorrow.
It would be a busy week for
what would happen? So again, like, what we see now as well is there's a huge amount of people we're seeing dying on the streets weekly, and it'll probably, maybe the HRB talked about it, because of drugs that are mixed with all sorts and everything, and nobody knows what's in them. So we have to accept the reality where we are, and like, look, there's no putting the genie back in the bottle. If we were able to get rid of drugs or banish drugs, it would have been done a long time ago. Drugs are becoming more prevalent. There's new drugs coming onto the market all the time, and we have to be realistic about where we're at now. Because it's interesting, the World Health Organization, who everybody followed by the letter through COVID, has said and stated that decriminalisation is the best way forward. So the question is, we take so long because of our fears to get to the place where we'll do something about it, because we see things as too radical. But a lot of the policies are just pragmatic, and the question is, how many more people will have to die? How many more people will have to be locked up? How many more people will have to have their lives destroyed before we say, do you know what, let's just do it?
Yeah,
and that's the question.
Sharon, we don't yet have, because obviously with COVID things have been delayed, but so we don't even yet have a true figure on the, I suppose, an update on the drug deaths at present.
So I think that's due, and there's people here from the HRB, so I think the drug-related death index is the next update will be in August. Yeah. But in relation to drug-related harm, so often when we hear about drug-related harm, we hear about, the medical effects. There are other drug-related harms, and having a criminal conviction is a harm for your future development. So when we're having these conversations, I'm not a drug policy expert, I'm a psychologist, so the drug policy experts can talk about that. But it does involve conversations from sociologists, drug policy, law, medicine, psychology, community, youth and community, addiction, mental health. And every single person there is entitled to be heard in an equal way. Because I think sometimes our focus is too narrow if we say, we know that some people who use drugs, have mental health related issues, and actually it can be sometimes difficult to know which one came first. Actually, one of the largest studies that was done was by Kessler et al. And what Kessler et al. Found was that anxiety and depression have their onset under the age of kind of between 11 and 15, but substance use disorder is much later. So that kind of puts an end to the chicken and egg thing. And I have worked with young people, and often they don't, when they come in and they might have a drug issue, they could come back to us 10 years after. I still get contacted by young people I met 15 years ago or 20 years ago, and they'll say, I didn't tell you this, but this is what happened to me, and I wasn't able to say it. If somebody comes in and says, I have this drug problem, you can't always assume that you know absolutely everything about them, because particularly in relation to abuse, it's often not disclosed.
And that was the point that Philly made. Philly, I'm conscious that you're on air this afternoon. You're actually working. You're going to do punditry on a game. I know you'll try and stay with us for as much of the Q&A as possible, but just in case you have to scoot away and do some work, what is the main message that you want this assembly to the many people who are listening on live stream? What's the main message you want to say to them today?
Well, in particularly to the assembly, that, you know, it's not very often you get a chance in your life to make a big difference in society for good, basically. And I think it's something, without putting pressure on anybody, I think it's a great thing to be a part of. I'm definitely privileged to be a part of so many brilliant people, and it's been a journey for me. But I suppose the crucial thing is, and someone from HRB might correct me on this, but I think since our existence of our policy, our deaths from drug deaths have increased by 225%. So it's not working for us at the minute. And if you find it hard to really connect with change, or you know, if you don't have a loved one or a friend that's struggling with addiction, I suppose I'm very lucky. I have a 1-year-old child now, and you know, every time I think of my brother, and I look at my son, I think of what my mum and dad went through and the pain and suffering they went through to lose a son. You know, and not only to lose a son, but all those years from the age of 14 to 31, the pain and suffering they had to go through and carry. And probably when he was diagnosed with schizophrenia, not understanding all of that time, why he was doing these things. So if you have a child, or if you have somebody that might, you know, possibly have trauma at a young age, and they start to try fill that void with a substance, you know, what way would you want them to be treated? Would you want them to be incriminated? Would you want the intervention to be done through criminal justice, or a public health-led approach? And yeah, so I think it's just important for all the people that we have in all our graveyards that hadn't got the chance, you know, with possible change. You know, I think the assembly can help that and possibly save lives, and also impact families and communities.
I really appreciate that. And Philly, if we lose you, we'll understand that it's because you have to step away. You know, as Paul said, all we can do in this panel today is skim the issues, really. It's in May, I think, that the real substantive discussions are going to take place. But for the next 15 or 20 minutes or so, we are going to open it up to the floor. I think we have roving mics, and we would really encourage you to take part in the discussion. And as I say, Philly, we'll try and stay with us as long as possible. For who's playing today that you're commentating on?
Fermanagh and Derry.
Fermanagh and Derry, good man. So listen, the floor is open for questions. So if anyone wants to just put up their hand, perhaps let us know what table they're from. We would really, really like to have some of your questions for the panel. This gentleman here, table 3.
Hi, thank you. With the growing technological sophistication of criminal gangs, does the ease of access to drugs on the dark web black markets and things of that like make supply side policies ineffective? And would it be more effective to focus resources on treating the mental health and socio-political or socio-cultural roots of the issue rather than marginalising addicts with criminal legislation?
Philly, I might just, if you're still with us, I might just bring you on that. The question is relating to, you know, the growth in technology and the impact on the supply side. Portugal was interesting because it raises the interesting question, well, does it free up resources, including criminal justice resources, if we don't penalise people, let's say at the lower end of the scale, the personal use scale, does it free up resources to look at the supply side?
Yeah, I was lucky to travel to Portugal. I'd done a documentary on decriminalisation, so I travelled to Portugal to look at the model that they used, and that has been studied immensely over the years from across the world. And I think they have, you know, definitely been the front runners in terms of decriminalisation. But they will all, when you speak to, and I know we have a meeting in a couple of weeks, and we'll have best practice for internationally kind of being the topic, but when they decriminalised drugs, decriminalisation was the key word, but it wasn't really the key thing to the success of Portugal. It was the multidisciplinary approach that they wrapped around that, the resources that they wrapped around it, and the investment that was generally pushed into the criminal justice system was now being pushed into the public healthcare system. But what they found was, yes, crime increased, but it increased on the basis that they went after drug dealers, not people that were struggling with drug addiction. And I was, again, very lucky to sit on one of the meetings of somebody that was caught with personal use of drugs. They were brought into a normal office block. They were sitting in front of 3 people. There was no police there or anything. And they were just asked simple questions like, you know, have you got a problematic issue with drugs? And the person said no. And it was like, okay, that's fair enough. This is the direction you go. And I said, well, what happens if they did? And this is they would have been sent on a certain program. So, and there's so much more to Portugal's levels of the layers, I suppose, of what they did to make an impact on their metrics around this topic. Like, for example, they would have had methadone buses pull up on the side of the road, and you would have people very like similar to seeing an ice cream van. It was kind of, I was kind of taken back that, you know, do people not feel ashamed walking up to this bus? And there was nothing like that. It was people pulling up in suits, people driving off in cars. It was people on methadone for 20 odd years. Now, my brother had a different experience with methadone here in this country. Every time he went to get his methadone, which would make him more functional to get back into work, employment and everything else, he was stopped by the guards because the guard station was on the way. So we had to eventually send him out to Bray to get his methadone, and he'd get a full bottle of methadone, which is like, you know, it's incredible to think that, you know, you're getting your full supply for the week. This person needs this drug to, I suppose, overcome any psychological pain he might have, but he has a full bottle of this, and, you know, it's very dangerous. So for me, Portugal have got there's really good parts to it. They'll also say there's things that they needed to get better at. I think for us, we need to look at different elements from different countries and find what works for our country. But decriminalisation in Portugal was definitely a success in terms of the stats and the statistics that you'll see.
Pauline, one of the things that you were raising, obviously the state's resources aren't infinite. There's pressure on all areas, but it's that investment piece in the public healthcare side of it that is critical, isn't it?
Yeah, it is. And, you know, we need to put in place services that are accessible. And what I mean by that is that, you know, currently our configuration with our drug policy and drug responses is you can go to the wrong door when you need help. So as a person, you know, as a person who uses drugs dependently, coming with the trauma, the reasons why we're using those drugs, as we've heard about, you know, you can seek support from the mental health service, and they may say, well, we can't actually assist you right now until you're not using drugs. And then you may seek the drug service, who may assess you as being not appropriate for their service.
And if you're pregnant?
Because your mental health, then you might be a pregnant lady. Many services won't be able to offer you that support. You know, so there's just multiple barriers. So, you know, if we're looking at increasing our public health response, then we need to increase the service delivery. We need to enhance and make sure that that's evidence-based. We need to make sure that it's multidisciplinary, i.e. we've got everyone at the table that's needed. So, for example, for a pregnant woman or one with young children, you know, we have to have TUSLA at the same interplay as the addiction service. We need to, one example would be where there's a consultant psychiatrist comes into the addiction service and provides a satellite service to assess the level of mental health that's there after a period of time. You know, there's good practices that we have in Ireland too, that we need to invest in and resource, as well as what Philly is saying at that international level too.
Okay, I'll just say, just to another table, this lady here, and then this gentleman at table 12. So we'll just go to, I've lost the table number.
Hello, how are you? Don't you think that the decriminalization will increase crime, drug dealers, instead of like the law in Switzerland, the drug policy, control legalization will be proven that this method is extremely effective? The control legalization, like in Switzerland.
Yeah, and this isn't a policing panel, but Andy.
Well, I think, like, I suppose we have to ask a question as a society, like, why is there a never-ending supply of young people, mostly men, who are seen selling drugs as a form of employment? You know, and it's not by accident that the majority of them come from one community over the next. I think Morris Devon was a, I can't remember, there was a book written by called Young People in Contemporary Ireland, and they found every young person wants a bit of money, a bit of status and a power, but how you acquire that in one part of the city to another is vastly different. So the argument has to include opportunities and addressing poverty in communities where they come from, because like we'll talk about the drugs and the drug trade, and we'll talk about the successes of taking down particular gangs, but drugs never go away, and the people who are looking for opportunities will always be there to fill those gaps as long as there's no opportunity. So it's the multidisciplinary approach won't be dealt with, has to include providing real life opportunities. Like, we're working with people now, and they're coming up through the system and they're coming up through communities, and they don't see a future. They don't see, even now, like, I mean, if you follow the rules and you get a job, it can be even hard to maintain a standard of living or a house. And people want a quality of life. And if they think, if you're from a community where drugs are around and it's an opportunity and selling drugs is there, you know, it's not always, like, not all drug dealers are evil or bad. You know, the majority of drug dealers are out there probably just sell drugs to their friends, but they do it to make money. So poverty and opportunity is how you resolve that problem.
But it is, Sharon, you know, you even just see it in the children's court, you know, the children's court where children are being used as drug mules, they're on the front line of it, but the criminal law has to intervene somewhere to try and break the chain of supply and demand.
Yeah, so, I mean, it's whether the criminalisation of it hasn't worked. So that's the reality is, you know, we know that more and more people, and like Andy said, you know, if you went back 30 years ago in Ireland, the drugs only appeared in particular parts of Ireland, and now you can get them everywhere. So that hasn't worked. One of the things I think is, you see, that people sometimes talk about decriminalisation and legalisation. Legalisation, you know, is happening in other places, and where they have had difficulties with legalisation is they have excluded people. So if you look at in California, for example, the black market has continued there. But the reason why the black market has continued there is because the people who were involved in selling drugs before they legalised it were primarily black people in that area. 98% of the people who own legal cannabis shops are quite wealthy white people. So, like, just what Andy said is, like, if you take it away and you legalize, and then you keep people and you don't address those issues, then you're going to end up with those issues. So people often sometimes when they talk about it, they present these issues in a very black and white way. So they might say, oh, if you look at legalization and it still has a black market, why? So, and every time I hear something, the next question I say to myself is, why? Why? And then keep digging and digging, and then you realise it's because they fixed one bit and then left this bit and then left those people still in the same difficulties that they were in before.
There was a gentleman, I think, at table 12, and then I'll go to the gentleman in front of him.
Thank you. Just to step away from decriminalisation for a second, does this country at this present time and moment have the facilities to assist every person that is seeking treatment at this moment? No. And I believe that it would be, but if we take an overall holistic approach like you had mentioned, do we even have the expertise or the facilities to even come close to addressing that on a holistic approach? Thank you.
Pauline, I think that's maybe for you, because I think what you've consistently said all today, it's all about access. It's all about access to services, and particularly when you look at the complexity of the pathways into drug use, how can we or should we resource that whole, I suppose, the complexity, the intersectionalities, and the fact that it would need very, very big multidisciplinary teams to come together?
I think investment will be needed, and I think we will need to increase and target service provision. But if we look at this through the lens of what we've presented here around the intersectionality element, so it's the homelessness, it's the poverty, it's you know, so it's not just the drug response or the drug policy or the service response, it's across the sector. So, you know, we are looking at needing to increase housing access. You know, that's another response too. But if we're looking purely in terms of the services that we have and what scale up would we need, well, what I can say is there's waiting lists for residential treatment centres across the country today. What I can say is that we know in a previous conversation Andy and I had around the restriction around detox. So if you're in a position and you want to access detox, that's a very difficult thing to do because you may be using multiple substances. So, you know, we need to look at the exact services that we have and we need to map the upping of those. One piece that I would raise a red flag around, I think, when we're looking at the current service delivery and the staffing and the skill and the development of the workforce to be able to handle the increase in service delivery that's required, is pay parity as an issue across the voluntary and community sector as well. What I mean by that is just, it's basically as Section 39 organisations, the state agencies, you know, are in a different salary than the Section 39 who are providing the service on behalf of the state. So that's a real challenge.
And everyone as well is competing
competing
for funds. There was a gentleman, I think we've lost Philly, but just,
yeah. It's just, you know, when Pauline is saying there, you know, what we would need in terms of investment, we need that anyway. If we have status quo, if we change nothing, we just decide, oh, well, everything's grand, we'll keep going. Or we decide that we're going to do things differently. No matter what way we go, we still require those additional resources anyway. Today. So whether you change or not, and actually if you do change and you do have more evidence-based policies, what you will end up doing is reducing costs in the future because you're reducing, you know, if you
invest now to reduce later on.
Sorry, just in another point, Sharon's just reminded me there, the cost of a prison, someone in the prison system for a year, I think it's in the region of 83 to 85,000. The cost for someone, let's say in an intensive residential treatment service for a single person could be somewhere in the region of 13,000. For a mother and child in the region of 24 to 25,000. So, you know, that there's, you know, over time, the resources are there to reinvest back. And just to finish on this, when we look at, so for example, we tracked, we conducted a longitudinal outcome study of the people who had come through our services and published it in 2016. And it showed that 7 out of 10 of the people who came through the service were illicit drug-free 2 years after treatment. Why? Because 100% were back in contact with meaningful relationships in their lives. 98% were not engaged in any criminal activity, and almost just shy of 50% were engaged in education and training pathways. You know, that's the capital that assists people to have the quality of life.
And to get that full recovery. There was a gentleman, I think, here at this table, and I might have just time for maybe one question from the back, and then we'll bring the session to a close before you go into your deliberations. But would you like to go ahead?
Yeah, thanks. Very interesting discussion from the panel. I think we probably all appreciate that there's a spectrum of different types of drugs, from recreation to very serious. And so I'd just like to get the panel's view in terms of decriminalisation. Are you in favour of decriminalisation across the board? Would that be useful? Or is it more for the more serious drugs as opposed to the recreational drugs? Just like to get a sense there for what you think.
Sharon, I think this is something that when you were tweeting earlier this week, you were saying some are recreational, some are using it for medical use, some have dependence. They are not the same things. And perhaps where people struggle when it comes to the debate around regulation, legalisation, decriminalisation, is that there are different types of users and different types of drugs that they are using. So I think that's perhaps why some people struggle with any liberalisation of it, because they will say, well, there's a different type of user, and we might have more empathy for the type of human experience we've been discussing in such really strong and harrowing terms today. Would we have as much empathy for the recreational user who can make their own way?
Well, if we think about drug-related harm beyond, then having a criminal record is a drug-related harm. So if you, when the HRB put up their statistics earlier on, you can see there's quite a large chunk of students who use drugs. Adolescents, when you're developing, in order to be old and wise, first you need to be young and foolish. I'm very lucky that during my adolescence there was no such thing as a mobile phone. So most people here will have done things during their adolescence that they wouldn't dream of doing now, because you'd be afraid in case you know, break a hip or something. But, you know, if you have a 17, 18, and a 19 or 20 or something, and they're using recreationally, and they end up with a criminal record, that is going to be drug-related harm, and it will limit their opportunities in life. And then sometimes when you think about decriminalisation, sometimes people say things like 3 strikes and you're out, which will definitely not work for, if I was somebody who was dependent on heroin, for example, I would use those all up by lunchtime possibly, because I would have to. So I think when we think about drug-related harm is to think about the impact of a conviction. I think James Leonard from the Tunaris spoke about this. He has, you know, convictions as a result of his experiences, and he has a degree and he has a master's. And there are times when there are things that he wants to do that have become very, very complicated. So, for example, if you were invited to go on the board of management of a charity, you are not allowed to if you have a criminal conviction, and you have to go to court and you have to ask for permission, even if that was 20 years ago. So I think it's not helpful always to distinguish between. And then the other thing is what are we saying about recreation, people who use drugs recreationally? So,
and also those who use it for medical use. You know, it's not. It's
yeah, you know, and some, you know, you could say, oh, I don't like the idea of somebody using drugs recreationally. I don't have to like it. I don't have to like it. I have to say, does it impact me? Does it impact on them? Does it impact on the rest of society? If you want to do something at home and it's not having any impact on me or anybody else, you know, that's your business. And actually, the route of transmission is a problem. So if you look at cannabis, for example, Professor David Nutt from when he was in University College London, he looked at harm, and cannabis is one of the least harmful. But actually, if I was, you know, 26 or 27 and I was going to university and I was engaged in using cannabis, and because I didn't drink alcohol and I ended up with a criminal conviction for cannabis, that's going to have a big impact on my ability to progress through life. And you might say, well, Sharon, I don't want you to use cannabis. And I say, well, you know, I eat it. I'm just conscious, actually, because I know Professor Ivers had a slide with Sharon in it, and I don't want anyone to think that that was me. But if I decided to go home tonight and say I was going to have a cannabis cookie, if I smoke cannabis, that is bad for me. Smoking's bad for you. But if I go home and I say I'm going to have a cannabis cookie, it has, in terms of somebody my age, you know, I don't have, you know, an ongoing mental health difficulty or anything like that. And then so then what you're saying to me is, no, I don't want you to have the experience of it. So it's teasing out all of those things. It's just
it is teasing out all of those things that is simply impossible for us to do in this time. Before I hand it back to Paul and back to the floor, I just want to ask each of you very, very briefly one final question. It's the question I asked Philly McMahon before he had to leave to go off and do punditry for Fermanagh and Derry. And I'm going to start with you, and just to really, really bring it back to the people who use drugs and their families, their experience, that person-centred perspective. What is the message you want the Assembly going away with today?
I think it's, look, it's Philly said, there's great hope in this room and everyone's rooting for you, but we have to be realistic and remember this is a matter of life and death, and there's a lot of people depending on policies that are centred around people. So I would encourage you over the next couple of months to seek out and demand to hear from the people who are most impacted, who have the most experience. Because if we create policies without them, they won't work and they'll further marginalise them. But if we listen to them and let them drive the change and be part of the solution, we will have better outcomes for people who use drugs, their families, their communities, and everybody in society.
Thank you. Sharon?
I would say that when you're thinking about research in the area as well, is to always, sometimes studies are presented in their correlation. So they'll say if you do X, then you have Y. Correlation is not a causation. So I might do X and Y might happen, but they might not necessarily have happened because of each other. So always say why, and it's when it's like the legalization. Why is there still a drug? Why? So always asking why, and remembering that there is no one expertise in the area, and actually the people who have the most expertise are often not heard, and they're the people that are talking about.
And they just finally, Pauline, are the people that Coolmine has been working with for 50 years. What's your message to the Assembly today?
And I think my message to the Assembly would be, if we are truly looking at a public health approach and we are looking at reducing the harms associated with drug use in Irish society, make sure we have the services available to support the people when they need them.
Absolutely. Well, listen, as I hand you back to the Chairman, we could only skim the surface. We wish you well, all of us, in your deliberations in May, and I'll hand it back to you, Paul, but thank you very, very much, and please give one of your